Hi, this is Dr. Arpitansu, and today we're going to talk about the heart pathology. First, we will do the revision of the normal heart, and then we'll study about the IHD, which is the ischemic heart disease. Okay, so let's begin. So, about the normal heart, the weight of the normal heart averages approximately 250 to 300 grams in the females, and 300 to 350 grams in the males. And the heart is enclosed in a double-walled sac called as the pericardium. The pericardium consists of an outer fibrous layer called as the parietal pericardium and an inner layer called as the visceral pericardium or the epicardium. This we know from the first year, okay, that a heart is enclosed by the pericardium, okay. Now, what are the layers of heart? The heart is composed, the heart wall is surrounded by three layers, okay. The outer layer is called as the epicardium, the middle layer is called as the myocardium, and the innermost layer is called as the endocardium. And the endocardium merges with the endothelium, which lines the blood vessels and covers the heart vessels. That is the valvular endocardium, okay. And the usual thickness of free wall of the right ventricle is 0.3 to 0.5 centimeter, and that of the left ventricle is 1.3 to 1.5 centimeter. Therefore, the left ventricle is more thicker than compared to the right ventricle. An increase in the cardiac weight or size is termed as the cardiomegaly, and thickening of the ventricular wall is called as the hypertrophy. And an enlarged chamber size is called as dilation. So whenever there is an increase in the weight of the heart, so we call that as a cardiomegaly. And if there is a thickening of the ventricular wall, then we call it as a hypertrophy. And if there is an enlarged chamber size, then we call it as dilation. The myocardium is composed of the specialized muscle cells, cardiac myocytes, and the basic contractile unit of the cardiac muscle cell is called as the sarcomere, okay, which is composed of thick and thin filaments containing the myosin and the actin, respectively, along with the regulatory protein, troponin, and the tropomyosin. Okay? The striation appearance of the cardiac myocyte is due to the specific arrangement of the sarcomeres. The sliding of the actin filaments between the myosin filament toward the center of each sarcomere is the mechanism responsible for the contractility of the cardiac muscles. Okay. Now, beside myocyte, other cells that are present in the heart include the endothelial cells and the fibroblast. And the cardiac myocytes contain a structure called as the intercalated disc that join the individual cell to allow the mechanical and electrical coupling. So you can see this is the outer pericardium, this one, and this is the inner pericardium. In between them is the pericardial space, okay, and then this is myocardium present with the striation, sarcomeres, and then lastly this is an endocardium which merges with inside of the heart. Okay, these are the three layers of the heart. This was the outside and this was the inside. Now, vascular supply of the heart. We have to know a basics of the blood vessels which supply the heart itself. Okay, and there are three major epicardial coronary arteries that perfuse the heart. The first one is the anterior descending branch of the left coronary artery, we call it as the LAD, and which supply most of the apex of the heart, the anterior wall of the left ventricle, and the anterior two-thirds of the ventricular septum. Second is the circumflex branch of the left coronary artery, give rise to the posterior descending branch called as the PDA, and thereby perfuses the posterior third of the septum. And the final or the last is a right coronary artery, RCA, which supplies the right atrium, right ventricle, interventricular septum, and assay node and the AV nodes. Majority of the perfusion of the myocardium by the coronary artery occur during the ventricular diastole. Remember that. When there is no compression of the cardiac microcirculation due to the cardiac contraction. So this is the left coronary artery and this is the left descending coronary artery, okay, you can see, and this is the right coronary artery, okay, you can see over here. And this right coronary artery, when goes to the backward, it gives a branch called as the posterior descending artery, PDA. Over here you can see this is the left circumflex artery, this one, LCX. So this is the left ventricle, this is the right ventricle, and this is the right atrium, and over here this is the left atrium. Okay, so this is the coronary sulcus. In the coronary sulcus we have a left circumflex artery, and this is the left coronary artery which is descending and forming the left descending, anterior descending, or the interventricular artery between the right ventricle and the left ventricle. Over here we have right coronary artery which is passing through the coronary sulcus, or the atrioventricular sulcus, right coronary artery between the right atrium and right ventricle. And this right coronary artery, when it goes backward, it forms a branch called as the posterior descending artery called PDA. Okay, so this is the basic vascular supply of the heart. Now there are types of heart diseases. Okay, there are 5 majority type of the heart diseases that we have to study. First is the IHD that we are going to talk about today. It is ischemic heart disease. Second is the hypertension or the hypertensive systemic pulmonary heart disease. Third is the non-ischemic primary myocardial disease, congenital heart disease, and the valvular heart disease. Now let's talk about the ischemic heart disease, that is the IHD. Now, IHD is a term for a group of closely related syndrome resulting from the myocardial ischemia. Okay. Now ischemia is more harmful than the isolated hypoxemia, that is the insufficiency of oxygen, and it is characterized by the insufficiency of oxygen, decreased availability of the nutrients, and decreased removal of the metabolites. Okay. Now, coronary atherosclerosis account for myocardial ischemia in more than 90% of the cases. Remember that. Okay, and therefore IHD also called as the coronary artery disease, CAD, or coronary heart disease, CHD. So this is the important point to be remember. This that coronary atherosclerosis is the main reason for the ischemic heart disease in 90% of the cases, and it is also called as the coronary artery disease or coronary heart disease, CAD or CHD, because of this reason. Okay. Now, what are the clinical syndromes which are associated with the IHD, that is the ischemic heart disease? First one is the myocardial infarction. Second is the angina pectoris, and there's three types of the angina pectoris, that is the stable angina pectoris, pringimental or variant angina pectoris, unstable or crescendo angina pectoris. Third, we have the chronic ischemic heart disease with a heart failure, and fourth, there can be a sudden cardiac death. Okay. Now, the clinical syndrome are the result of a complex dynamic interaction between a fixed atherosclerotic narrowing. This atherosclerotic narrowing in the vessels, first reason. Second is the intraluminal thrombosis overlying a disrupted atherosclerotic path. Now, over this atherosclerosis or atheroma, if there is an intraluminal thrombosis which overlie this disrupted atherosclerotic plaque, second reason. And the third reason is the platelet aggregation and the vasospasm. Okay, so these three clinical syndrome or the complex dynamic interaction forms the clinical syndromes in the ischemic heart disease. Moving on, what is the role of the coronary obstruction in the pathogenesis of IHD? We will hear about it. Now, we have already seen that 90% of the cases of the IHD is caused because of the atherosclerosis. So that 90% of the patient with the IHD have underlying atherosclerosis. We know that. And with the presence of solitary or multiple lesions, causing at least 75% reduction of the cross-sectional area of at least one major artery. Now, because of this atherosclerosis, the lumen of the vessels become reduced from about 75%. Okay. Now, common locations for clinically significant stenosis include the first several centimeter of the LED, that is the left anterior descending artery. We have seen over this region of the heart, and LCX, left circumflex artery, over this region of the heart, and RCA, right coronary artery, over here. Okay, so LCA, left anterior descending artery, which was present between the right ventricle and the left ventricle. Its first few central centimeter are the common center for the common location for the significant stenosis. Second artery is the LCX, left circumflex artery, which was present between the right atrium and the left atrium and the left ventricle. And the third is the entire length of the RCA, that is the right coronary artery, which was present between the right atrium and the right ventricle. Its entire length gets significantly stenosized. Okay. Now, usually 2 to 3 arteries are involved. We have already seen that LAD, LCX, or RCA may be mostly involved. Major secondary epicardial branches may also be involved, but atherosclerosis of intramural branches are rare. Okay, so you can see over there that this is the left descending coronary artery, and over here this is the normal artery, and over here there is an atheroma or the atherosclerosis, and because of that the artery has been narrowed by 75%. Now over here we will see how the atheroma or atherosclerosis gets formed. Okay, so basically there are 7 or 8 steps. First, because of any endocardial injury or endothelial injury, there is an endothelial dysfunction. Then few things occurs in then the permeability of the endothelium increases, and because the permeability increases, the low density lipoprotein starts entering into the intima from the lumen and get oxidized and form the oxidized low density lipoprotein. Okay. Secondly, what happens, the monocytes in the excess circulation starts attaching to the endothelium line. Also, there is an adhesion of the platelet over the endothelium line. Okay. Now this monocyte, which was adhered to the endothelium, it enters the intima. In the intima, it takes up the lipid and forms a foam cell. This foam cell secretes the PDGF, okay, platelet-derived growth factor. And the platelet, which was adhered to the endothelium, it also starts secreting the PDGF, which is the platelet-derived growth factor, and also the endothelium injured cell itself secretes the PDGF. Now all these, now this PDGF, what it does, it goes to the media where the smooth muscles are present, and it migrates it into the intima. You can see over here. So this is the smooth muscles, and this PDGF starts its migration towards the intima over here. You can see, and yeah, and because of that, extracellular lipid and necrotic debris are present. We will see about it again. Okay, sir. The pathogenesis of atherosclerotic plaques, atheroma, is thought to begin with the endothelial cell injury we have seen over here, and because which result in the endothelial increased permeability and enhanced leukocyte adhesion, monocyte adhesion we have seen, and altered gene expression. Endothelial dysfunction also promote the platelet adhesion. We have seen about that, aggregation and release of the factors and cytokines, growth factor cytokines. Now PDGF, which is a platelet-derived growth factor, released locally by the adherent platelets. We have already seen. Okay, this platelet, it secretes the PDGF. Okay, so platelet-derived growth factor released by the locally adherent platelets. Dysfunctional endothelial cells and infiltrating macrophages promote the migration of the smooth muscle cells, that is the SMCS, from the media into the intima and increases the smooth muscle cell proliferation. And the platelet also releases transforming growth factor beta, TGF beta, which is chemotactic for SMCs and induces interstitial collagen production. So this is how the atheromas are formed. Now, second dynamic complexion that we have seen, which result in the clinical syndromes of IHD, was the thrombosis. That is the now we will see about what is the role of coronary thrombosis in the pathogenesis of IHD. Okay, the acute transmural myocardial infarction is usually caused by the superimposition of a thrombus on a disrupted, previously partially stenotic plaque, causing total occlusion. Okay, now this thrombus is added by the thromboxane A2 and the other platelet constituent, fibrinogen and lipoprotein, which inhibit the fibrinolysin. Lastly, there is a role of the vasoconstriction also in the pathogenesis of the IHD. Vasoconstriction or the spasm may contribute to the pathogenesis of the pharyngeal angina as well as the acute myocardial infarction, and it is induced by the circulating adrenergics, release of the platelet contents, impaired secretion of endothelial cell relaxing factor, that is the nitric oxide example, and release of the mediators from perivascular cells like mast cells. Now we will talk about angina pectoris now. Now, angina pectoris is defined as a symptom complex of the IHD characterized by the paroxysmal recurrent attacks of substernal or precordial chest discomfort. So below your sternum, okay, you will feel that there is a constructing type of pain, squeezing or choking or knife-like pain or discomfort you will feel in your chest region, and it is caused by transient from 15 seconds to 15 minutes of myocardial ischemia that falls short of inducing cellular necrosis that defines infarction. So angina pectoris, whenever a person comes with a complaint of that there is a constricting, squeezing, or a choking, or knife-like discomfort or a pain in his chest region below the sternum, and it is present from the last 15 seconds to 15 minutes, then there are the chances of myocardial ischemia. Okay. Now there are three overlapping patterns of the angina pectoris. The first is the stable, also called as the exertional or classical angina. What happens in a stable exertional or classical angina is that there is a reduction of coronary perfusion due to the chronic stenosing or coronary atherosclerosis. Okay, the heart is vulnerable to ischemia wherever there is a increased demand, that is a physical activity and emotional excitement, and it is relieved by the rest or decreased demand of and nitroglycerin decreases the cardiac work by dilating the peripheral vasculature. So in the stable or exertional or classical angina, it increases when the person does the exercise or any physical work, okay, and it reduces when the person is at rest and by the use of the nitroglycerin, which dilate the peripheral vasculature. Okay. The second, we have the pringimental variant angina. It is an uncommon pattern of episodic angina and occurs at rest and is due to the coronary artery spasm. Okay, and attacks related to unrelated to the physical activity, heart rate or the blood pressure, and there's an elevation of ST segment on the ECG which is seen, and it responds promptly to the vasodilator like nitroglycerin and calcium channel blockers. Okay, so in the pringimental it is uncommon and it is also relieved by what the using of the vasodilator like what nitroglycerin and the calcium channel blockers. Okay, and in the pringimental variant you will see an ST elevation. Okay, so this okay, in the ECG you will see the ST elevation, and this is unrelated to the physical activity, that is it does not increase when the person does the physical exercise or any physical work. Last, we have the unstable or crescendo angina. It is repeated episodes of the pain with a progressively increasing crescendo frequency. Okay, often occurs at rest and tends to be of prolonged duration, induced by disruption of an atherosclerotic plaque with a superimposed partial thrombosis, an embolization or vasospasm, or both. The precedes acute myocardial infarction in myocardial infarction in okay sorry precedes acute myocardial infarction in many patients, also called as the pre-infection angina. So these are the three overlapping patterns. Over here you can see this is the stable exertional angina. It is the fixed blockage of the coronary artery from the cholesterol buildup or the atherosclerosis. You can oversee over here that there is a this yellow atherosclerosis or atheroma or the chloral deposition causes the narrowing of the vessels, and the symptoms occur predictably at a certain age, certain heart workload, and go away with rest. We have seen about that. And over time, the blockage gets worse and symptom occur earlier. Too much demand for the too long can cause a heart disease. And for that, we will give the nitroglycerin or we will ask the patient to rest. In the unstable angina, we have seen a previously stable blockage now becomes unstable. So if there was a previously stable blockage and it becomes unstable, then it is called as the unstable angina, and it attracts clotting factors. Symptoms come and go, and no longer just with activity. Okay, unpredictable this is, therefore it is called as the unstable, and very likely the vessels will be totally blocked off and cause the heart attacks. So over here you can see is a thrombus. And in the vasospasmatic or vasospastic angina, there is no underlying blockage, but the vessel wall clamps down and it squeezes off blood flow. And it is also prolonged. If prolonged, can cause a heart attack. Okay. So this was a type of angina. You can see over the diagram over here. This is a cholesterol deposition. There is a thrombus and there is a vasospasm. Thank you. In the next video, we will talk about the myocardial infarction.